It's Off Exit 10, presented by Capital District Sport and Fitness.
Oh, you want one of those, right?
What is this?
It's a nootropic drink. So I can't have energy drinks, and they're not good for you anyways, an energy drink. So this has 75 milligrams of caffeine from green tea and lion's mane and L-theanine. So helps
really?
with, yeah, some good.
Mind?
Yeah, crack one open.
Cool.
Shout out to Drink Alchemy.
Good.
Paul, I just ordered the apple flavored draft.
I saw that.
I put in our order. What do you think?
It's okay. Kind of tastes a little odd. I've been going through energy drink, not energy drinks, but sort of these L-theanine and whatnot for my kids because they're all, number one, nobody eats healthy, and
Well, do they want to have energy drinks?
I don't want them to have energy drinks, right? So I'm trying to figure out what is safe, healthy, and a reasonable amount of caffeine and all the other stuff in it. So
That may be one of the worst changes in youth health, health. Vaping's really bad, and obviously screens and devices being in that a lot. But energy drinks and the consumption of those,
and how easily accessible they are.
So this is another. Are we recording? Or
oh yeah, we're
all
live,
right.
baby.
Yeah, we're live.
Yeah,
we're rolling, baby.
So last spring it was. My daughter, she's having mood swings, whatever. She's 12. She's hormonal. This is somewhat normal, but I mean, just flipping out. I'm like, something ain't right here. And I thought back to my younger years and stuff that I may have done that may have now in hindsight triggered. I remember one day in college I took a caffeine pill, and that night I was just jacked up, I was walking around my parents' neighborhood in circles. I had all this energy, what the fuck, and I'm like, oh shit, maybe it was that caffeine pill I took at 5 o'clock. And this guy, one of the kids in school, was like, oh, take this, it'll help you focus. So anyway, I was like, something ain't right here. Anyway, long story short, one of my daughter's rooms, she had a bunch of those Celsius drinks,
dude,
right? And
yeah, and those aren't low in caffeine.
They are loaded. And I'm like, we haven't had a talk about energy drinks, but I'm like, where are you getting, we don't buy them. The kids know they're not supposed to have them. Like, where is she getting all these energy drinks? Well, days later anyway, we find more empty cans in her softball bag. Like, so she hangs out at the softball fields in East Greenbush, right? It's where kids go, and it's a great environment for kids. They kind of, she's umping, they're working a concession stand, kind of watching them grow, develop. I'm like, you cannot drink these energy drinks when you're there. This is a hard no, right? So my wife bowls with the one of the women on the board, and I was talking to her this fall. I said, last year Sam was drinking all these energy drinks at the field. I said, why do they have energy drinks at a concession stand?
Yeah.
She's like, that's a good point. I said,
yeah.
I said, seriously, I said, you should take them out because there's really no place for it. I said, quite honestly, they don't need soda. They don't need all this junk. I said, but the energy drinks we know are unhealthy for adults. What are we doing? 10, 12-year-old kids are getting these things, and then they're having one or two. I'm like, having heart arrhythmias, tachycardia, dehydration, all this stuff. She brought it up to the board this spring, and I'm kind of proud to say they took the energy drinks out of the concession stand this year. I think it's great.
That's
Problem
good.
solved. Done.
Boom. Done.
I thought you were gonna say she had some friend that was a plug that was sneaking her Celsius in the dugout.
Well, but I do think there were some kids who were allowed to drink them, and they were kind of it's like anything else, crack. It's like crack and everything else you're not supposed to use. Oh, try this, but. So for East Greenbush softball, I was happy to hear they took my advice, and they were like, yeah, this is a very valid point. We don't need to make money on these. We don't need them at the field.
What do you, for anybody pumping 200, 300 milligrams in their body a day, but for a growing body and a teen, what do you see as negative effects over time when kids are consuming these every day?
Caffeine is addictive, right? Anybody who drinks caffeine, and if you go without it, you get headaches, mood swings, right? And then you have your ebbs and flows. And I couldn't tell you the peak onset of caffeine and when it really starts kicking around. But any chemical that's going to give you, peaks and troughs is going to affect your mood. As a teenager, you have enough mood swings and hormone instability. So,
yeah, and from a cardiac standpoint as well.
It speeds up your heart rate, right? The reality is kids can tolerate it pretty good, but a kid who's not drinking enough water, drinking caffeine, then they go to practice, instead of their heart rate being sustained at 120 to 140, maybe it's 140 to 170, right? And then you get a kid who's on a hot day, it is already predisposed to be dehydrated. It's just going to trigger that more.
Yeah.
Is there an uptake in like ischemic events like in kids now, or the news just make that more like you just see it more because it's pumped out in the news more?
I don't see any direct correlation.
Yeah, I was just curious if like this increase in energy drinks.
Not yet. I think down the pipe again. I don't know that it's not so much ischemia as much as arrhythmias.
Right.
I'd be interested to see if more kids are going to the pediatrician with palpitations and things like that.
Right. More of an electrical thing. Then.
Yeah.
Yeah. Right. I appreciate you doing this, man. I think. Before we get rolling more, so you do direct primary care, which
correct.
When I was working in Boston for 2012 through until we moved back here 2018, we had a lot of clients at our gym in Boston who used direct primary care physicians, and came back here and it wasn't a thing at all. I think it's the same as we talked before we got on air, like cash-based physical therapy was a big thing when I was out there, was kind of just starting, and now there's a lot more of it in this area. But I guess explain to the people listening what a direct primary care is.
So it's kind of, the name says it all, right? Direct primary care, meaning that we removed all the intermediaries, all the insurance companies, and a hospital-based system. And I hate to say a lot of the regulatory bodies, but a lot of the regulatory bodies. And basically, I charge an annual fee. There's different price points, and you become a patient, and that means you need something, whether it's Saturday afternoon, hey, I just got bit by a tick, what should I do? Well, how long was the tick on for? Et cetera, et cetera. I could walk you through that over the phone. Versus, we come in for annual physical, manage blood pressure, chronic disease, but there's no copay, right? So it's not like the current model where, I got called by Mike on Saturday and I spent, 12 minutes on the phone with him, so I'm charging him for a phone visit and his insurance charges this, and now Mike has a copay. No, it's, hey, you already, you paid your annual fee. I'm here for you, and let's take care of things and keep you out of the urgent care and the ER and kind of the system that is so bogged down. How do we declutter that and get you access in an efficient manner? It's all about efficiency.
Yeah, because you've worked in a lot of different settings prior to doing this. Yeah. When did you start doing all this?
So we opened this practice in October of this year. This has been sort of an idea I've had for years. I always, years ago I worked with an LLC, and we were a private group. I've worked in the Federally Qualified Health Center, which is, non-for-profit, Article 28, kind of driven by and funded by grants and state monies, federal monies. I've been in the private sector. Then the private sector kind of got chewed up by the hospital-based system, and then I worked for a couple of hospital-based systems and urgent care, primary care, and then I've kind of always wanted to get back into more of a smaller, practice. And how do we do that?
Is it like an old school thing where like a doctor would, you're not going to people's houses, but like a doctor would go to your house?
I do actually. So I can, I've had a couple of patients who, I'll do house visits. It's not anything extra depending on the geographic location, right? If I have to start traveling 30 miles, out of my way to visit somebody, just, economics of it, I have to charge something. But so far, and again, I opened in October. I've had two people who were homebound. They both ultimately ended up on hospice, but, I knew the family, I knew them, so I was able to be sort of facilitated. And then, like I had this one woman, the husband called me on Saturday night. This woman had kind of taken a turn for the worse. And I knew the set-in, I knew the family, I knew kind of boom, boom, boom. All right, this is what we could expect. This is what might happen. I know so-and-so's goal was to stay home, so we're not going to send her to the hospital. Like, this is why we're here. This is why I'm here. This is, why she has these services in place, and this is what we're going to do. And she passed away peacefully at home. But, I'd stop by, once every couple of weeks, visit her, see, if she was progressing. She had a bed sore, so, check on that. This is somebody who can't get to the doctor's office,
Mm-hmm. So. Right. When you say private places are taken over by hospital systems, what does that mean?
Well, hospital-based systems. So I don't want to use any names and kind of disparage anybody, but it used to be a lot of private groups or individual practitioners, and then over the past probably decade, and this is nationally, this is unique to upstate New York, but nationally, all the big hospital-based systems have kind of bought out these private groups.
And then when did you first realize when you were practicing Like, hey, I can't do everything I want with somebody or spend the time I want. Is that because I'm bogged down by insurance and by billing? And is that something you've always
I
kind of
mean, it's
realized?
sort of always been on the radar, but before we were owned by the hospital, and we owned our basically owned ourselves, or we were our own business. We could say, hey, I know Paul's going to need at least 40 minutes, so I'm going to block out the 15 minutes after Paul's 30-minute appointment, and maybe freeze the next 15 minutes so I can kind of regroup a little bit, or I know I know Jordan's grandmother passed away last week, and he's probably gonna want to chat for a little bit about that, and
Right.
we'll check in with him. So I want to make sure he has some more time. Now it's just boom, boom, boom. You're booked every 15 minutes, and it's interesting. So a couple of things, we get audited as scores, and you go for your physical, you go to your doctor's office. I'm using the word doctor's office, nurse practitioner like myself, PA, your provider. Before you even get to your car, the secretary checks you out. A link gets sent to your phone, right, saying, "How was your office visit today with Ryan Marshall? Were you satisfied? Were you on time?" And then at the end of the month, we as providers all get these scorecards, right? And was the patient satisfied? And one of the questions is always, were they timely? Well, again, work for a hospital-based system. We had a policy that you could be up to 15 minutes late, and we couldn't say, "No, I'm not going to see you." So say I know that Paul's just perpetually late, right? Whether he's like my wife, who's just runs late, or he just quite honestly doesn't give a shit about other people's time, right? So his appointment was 8:45. He showed up at 8:53 in the morning, so that's when I'm starting my day. The 9 a.m. was in the office at 8:50. Now I got to see Paul, who showed up at 8:53, who's just starting to check in. So Paul's not getting the exam room until 9:02, and then Paul doesn't really care about anybody's time. So his 10-minute, 15-minute visit that he was 12 minutes late for, 13 minutes late for, he's already cut into that other appointment by 12, 15 minutes. So by the time you get to 11 o'clock, you're already 45 minutes late, right?
Right.
And then the patient's getting a text message saying, "How was your service? Was it timely?" Well, no, it wasn't timely. There's protocols in place to almost ensure that it's not going to be timely.
Yeah.
Yeah, it's dude, yeah, we see that. We see that a lot. We talked about, seeing PT clinics and clients that go there and get better care because they're able to be one-on-one with somebody. You got to feel like your job just becomes because you're not doing billing as the physician yourself, right? You have
in the hospital-based systems, you are. Yeah. When somebody leaves, you have to put a code in based on complexity and time.
Yeah, dude, it's just crazy how much you kind of get indebted. Like, when did our medical system first get so intertwined with all of these things, with insurance and with corporations and with...
So, I looked some of this data up over this weekend because I was trying to kind of, get ready for this and want to be able to give data, not just like, I think. So I just want to go backwards to the, the day-to-day operation. So now, everybody should have an annual physical, right? Like, it's a good idea. It's a screening exam.
What's the percentage of the population you think that actually does their annual physical?
So I would separate that by ages, right? Because 65 and older is your Medicare group, and that's called an annual wellness visit, and that's not covered. That's technically not a physical. So Medicare has now sort of mandated, really encourages everybody 65 and older or who has Medicare to get a Medicare wellness visit. Interestingly, a Medicare wellness visit does not include a physical exam. So if you come into the office for your medical wellness visit at 70 years old, you think it's your physical. There's no reimbursement for, blood vital signs. That's a separate office visit. So now you have an E&M code, which is your office visit. Now it becomes a problem-focused visit. Me listening to your heart and lungs, not covered by your annual Medicare wellness visit.
And this is a billing issue because it's not covered.
Well, it's not a billing issue; it's a bill and dream by the hospital-based system because now right. you have your E&M code, which is your focused office visit, and your wellness visit. What some of the insurance companies done, particularly locally in upstate New York here, is they have put tight constraints, and they actually weren't being accepted by a couple of hospital-based systems. They couldn't come to an agreement because they said we're not gonna send our patients to you, or we're not gonna get a contract. You're not gonna get a contract with us unless you can guarantee, I think it was like 65% of your Medicare patients will be in for office visits. So the insurance company has kind of got the noose around the hospital-based system next, saying you need to get your people in here, for care. I think, what's driving this now? Is it because the insurance company is really interested in the wellness and they want to make sure, people are getting their mammograms and their colonoscopies, or is it something to do with, okay, well, more people that you get to go for your mammograms and colonoscopies, more abnormal stuff you find, the more money you make.
Right.
I don't know what the driver is, but it's a pretty peculiar situation. I was working somewhat rural and on the border of two hospital-based systems. Let's just call it A and B. So I worked for hospital system A in a building where hospital system B had a imaging center. So I had the administration coming from hospital system A come and talk to me about what they call as leakage, which is when you refer to a different hospital-based system or a different, even if it's a private part, even if it's a private imaging center. They came down and said, wow, your breast cancer screenings are great, but, we're seeing a lot of leakage to other facilities.
And leakage would mean you're just referring out to a system that's not
to a different
theirs.
company. Right. So I'm like, yeah, well, the imaging center is downstairs. I'm not going to ask somebody who drove, 15 miles north to get to my office to go another 20 miles north so that they have the imaging done at your center, like just for reimbursement purposes. And there was some pushback. It's the same with specialties. They always want you use, they want you using their specialties. That's basically what the purpose of primary care in a hospital-based system is. It's a feeder program. That's, it's like the it's like a prep school or like the
Right.
minor leagues for baseball, right? It's like you just want to get people, so you have a venue to.
But which is right, good that a primary care is there to catch potential issues, refer out to get them fixed. But what if this place isn't geographically or even like a fit for that person in terms of I know
personality wise,
right?
Not everybody. There's cardiologists I know that. You like baseball, right? You hate doctors. You hate going to the doctor, but I know you like baseball, and I know if you go see this guy, you're going to strike up a conversation, and you guys are going to hit it off, and you're going to come back and see this guy.
Mm-hmm.
There's some people who are like, hey, I want every test done, right? I want every screening test, and there's other people who say, if something's wrong with me, maybe I'll address it. So you got to pair that patient up with the right provider, right? Because you don't want to send the person who wants nothing done to the cardiologist who wants everything done, because they're just not going to connect, right? It's going to be like, all you want to do is make money on me, or you need medicine. Well, you're just that you're just looking for kickbacks. So that's a whole separate dynamic.
So much of what we do in here and what you do is building relationships, is building rapport. And as you do that, it's like I want to do what's best for this person in front of me. Yeah, and that's a tough just kind of battle when the system you're in is encouraging you to keep feeding it and sending things one way. Yeah. So for you would be like, F it, I'll send to somebody I know they're going to be best with. Or other times you're like, dude, this is difficult. Like, I know this business I'm in for me to do well.
I send it to somebody who I know the person's, number one, you got to meet everybody where they're at, right? So there's no point in sending you to somebody if you don't, not that you have to love them, but if it's not somebody you're going to be able to connect with and work with, what's the point of going? Because you're probably not going to go back.
Yes. Yes, 100%. Yeah. So now doing what you do in a direct care model, do you feel like you have the freedom now and kind of to send people where you want, where it's going to be best for them?
Yeah, no, it's phenomenal. It's kind of like, hey, I think, you need a urologist. There's a urologist 7 miles down the road. Guess what? That's not the urologist I think you should see for this problem. I think you should go here. I saw a guy this morning who, has a bad tremor. I said, you know what? You can go north 40 minutes, but there's somebody who's really like the top of their game an hour and 15 minutes south. I'd probably just take the extra 30-minute ride and go to that person, because this is what they do. They do a lot of it. We don't have, that somebody who really specializes in what you need around here. And this person has the resources and the means to get in the car and go the extra distance, and they want to.
Right.
Well, I think the thing you said earlier on was like efficiency, and I feel like a lot of the times somebody will go in with an issue and it's not efficient getting to the solution. Like, there's so many steps they have to go through in order for them to either get a surgery or get physical therapy script or whatever it is that they need to get to. There's like 6 different hoops they got to hop through at first.
100%. Again, this goes back to like the requirements, right? So So you call your primary care provider office and say, hey, I've my shoulder's been bothering me for 3 weeks. Well, you haven't been in the office in 14 months. You need your physical. You're not even really a patient here. Okay, I'll schedule my physical, but can I just have somebody look at my shoulder? Well, no, we can't do that until you come in for your physical.
Right.
Yeah. That would be me. I'd be that guy. Calling for my shoulder. You haven't been in like, 10 years.
Which I think is fine, right? I think there's listen, like I said, I think everybody should get a health screening, a preventative physical once a year. Some people, it's not the way they were raised. It's not their beliefs. They miss their appointment and they can't get rescheduled for another 8 months because the system is so jammed up. So now the person's not going to have access to care because they missed one appointment, that kind of stuff.
Are there things you're able to include in a annual physical now that you couldn't before because of the system you were in?
Not really. I mean, if somebody came in for a physical, I always felt like that's kind of like their time, right? Now, there are times you have people with, complicated illnesses, diabetes, COPD, heart failure, renal failure, osteoporosis, depression, in 30 minutes, if you do want to get through all the screening stuff, it's kind of hard to if you have 7, 8, I mean, we have people come in 15, 16 diagnoses. You can't go through it all. Even in the model I'm in right now, I might say, you know what, we're going to work on the top 3 priorities right now, or what I see as being, emergency, or what's important to you. What do you want to focus on today? Mm-hmm. And you know what, come back next week. Because you know what? It's not going to cost any more money.
I was just going to say
you paid your fee.
I was just going to say that, like, you don't have to pay anymore. Like, you just come in next week, and as long as I got an opening.
What I do at my practice now is, you're here for your physical, or you're here for your screening exam, your annual exam. We're going to do labs. I'm going to call you in 3 days. If something comes up, let me know. Oh, again, going back to the diabetes or even depression, you don't need to come in to the office to tell me what your blood sugars are or managing blood pressure, right? Mm-hmm. You have a home cuff, write I tell people once a day, check your pressure, record it, upload it to the portal. I'll check your numbers. I'll give you a buzz. Mm-hmm. And we'll kind of, adjust meds that way. Or, if it's diabetes, talk about your diet. What'd you eat this day? We don't need to have you come in. And that, to me, is a huge barrier of care. Mm-hmm. Especially, during COVID, we went, everything all of a sudden, it was like, oh, telehealth, let's do telehealth. I found it disgusting that all of a sudden we went from, somebody who has recurrent UTIs would call, hey, I think I'm having a UTI. Well, you probably are. Mm-hmm. Right. Let's take care of that. And then kind of post-COVID, it was like, oh, you need to come into the office. Well, why do I need to come into the office?
Yeah, people got so accustomed to the ease of this telehealth.
But it makes sense. It's actually effective.
Right.
I may have somebody say, hey, you work in Latham. There's a LabCorp. Drop a urine off at LabCorp. I'll catch up with you. I'll have the results in my inbox in 2 days. I'll give you a buzz. Mm-hmm. Done.
Yeah, you hooked me up. Every year I don't learn my fucking lesson about poison ivy. I go into the woods, exactly. I clear my brush, and then, right, Paul? I'd be like, all right, in the portal, Ryan, here we go again.
It's an annual thing.
but that's a great example, right? Like, I know you get poison ivy. You don't need to take off of work, have a copay, come in the office, like, hey, I have this rash on both of my arms. It looks exactly like the poison ivy I've had the past 7 years when I do my yard work. Hey, guess what? What have we done in the past? Oh, actually, you know what? I don't need to ask you because it's in the record. I'm going to send in your prednisone. I'll send in the cream. Let me know how you do.
Why don't you wear long sleeves next time, buddy?
Like, okay. Yeah. Or hire somebody.
Probably that.
One of the two, Just at least that part. That way you don't have to get the poison ivy.
Yeah. How much are you talking like diet and exercise with people?
As much as I can.
They got to be receptive, right?
Well, people have to be ready to hear it, right? I mean, diet and exercise, it's kind of in the every disease process I just mentioned is affected by diet and exercise. Diabetes, COPD, depression, right? If people aren't eating healthy and getting exercise, tell people all the time, like, what are you doing for exercise? If I sat in the house all day and stared at the wall, especially, from March and April, man, are just pressure cookers. You got to get out. You got to release those endorphins, right? Because people who sit around, they don't exercise, they don't release the endorphins. What do you do to feel a little better? Yeah. Oh, I'm going to have a cup of coffee. I'm going to have a snack. I'm going to have a muffin. I'm going to have a cookie. And
Yeah, and especially here, right, with vitamin D, we just sat inside for how many winters? Or how many months in the winter not
Winters?
getting
7 or
sun?
I mean,
How many
it
months?
was
It felt
multiple,
like that.
It was multiple winters because
Yeah.
we went, winter. We had like a week of spring and then another
Back to
winter.
snow.
So you're right, multiple winters.
The monsoon season.
Yep,
past 3
monsoon
weeks.
season.
Yeah, and that. But yeah, it's a part of conversation.
Yeah, no, I definitely I try. Number one, I have a good relationship with. There's a nutrition group in my building, and I have sort of I don't know if it's called a deal, but I have a contract with them. So patients who join my practice have like a one-time consultation kind of covered on me. I have a rate with them, so I pay the dietitian basically to have again at least one consult with somebody to say, hey, what is your day-to-day look like? If they want to develop a more long-term relationship, then that's on them, right? And they could see if their insurance covers it. But most insurances don't cover dietitians.
Right.
Now, if you get diabetes, they'll cover a diabetes educator and a dietitian. But if you're a pre-diabetic, so like say your A1C is 5.7 to 6.4, not covered by a dietitian. You have hyperlipidemia, they won't cover a dietitian consult or a nutrition consult or a physical trainer, but they'll cover all the statin drugs in the world. Or now they have the PCSK9 inhibitors, which are the injections for high cholesterol, which are effective. But again, maybe if you exercise and lost weight.
Yeah, this is where just our system as a whole is way more reactive than preventative, which like, hey, when somebody's real sick, I mean, you need to have the care there and available. But to prevent people from getting to that point, things aren't set up like that.
So I just want to go back. So I took some notes kind of as I was getting ready to come up here and talk to you guys. You were talking about the exercise thing. I would encourage people when you go to your physicals, right? Get a printout when you leave the office. Get the printout of the I think it's called a health summary or visit summary. If you look at the bottom, there's a bunch of check boxes, and they're all gonna be checked. Discuss diet and exercise, check. Discuss skin cancer prevention, check. Discuss seatbelt use, check. Discuss safe sex, check. Discuss age appropriate vaccines and cancer. It's all gonna be checked, right? Because all this stuff is templated. You get put in a room. You get arrived, you get put in a room, the medical assistant, the nurse brings you in. All that stuff is just boom, because I think it's called, what used to be called meaningful use, which is like you have to, in order to get for reimbursement, you have to touch on so many preventative health maintenance measures. And it's all bullshit. I mean, it's not all bullshit. It's all real, but there's no way a provider is going to talk
Touching
about
all
all
those.
that stuff in a 30-minute visit.
He was just talking to me about seatbelts.
Yeah.
And then was talking about safe sex.
Yeah. Oh, and your healthcare proxy, live and willing, if you want to be a DNR. Going back to the wellness visits, right? I mean, you get 30 minutes to do a wellness visit. It's 20 minutes of Q&A. You have to do a PHQ-9, which is a depression screen, and you have to do the, food insecurities. I used to tell people because a year or two ago, the nurses or providers, whoever did the intake, had to ask each person, "Are you worried about where your next meal may come from?" I started telling people, they're like, "What is this?" I'm like, "Tell them you are. See what they're going to do about that. Are they going to send you out with a care package? No, they're going to be like, oh, that's another hurdle for us to tackle."
Right. Yeah. Do you feel in a way just like there's this weight off your shoulders now, not having to know you have to do all these things?
It's huge. I mean, people, number one, patients are satisfied, right? Patients are they're there because they want to be. Right? They're not like held by handcuffs. Like if you want your medicine, you have to come in.
Yeah, that's an interesting point because we live in a world, in our gym world in here, where people are here, similar to you. They're paying us higher dollar, and they're here because they want to be here. It's like we rarely deal with the very unmotivated, somebody who doesn't have incentives to get healthy, doesn't have specific goals. So yeah, like we're spoiled in a way like that, where we kind of live in this bubble in here where people are.
So you talk about the way of the world, right? So it's going back a while. I had somebody commute in about 40 miles to come see me, which is sort of, what's the word?
That's far for a primary visit.
Yeah. Sort of flattering, right? Oh, they think so much of me. So this person was taking Medicab, which is when Medicaid covers their transportation. And I knew them a long time when I worked in one of the non-for-profits, and they wanted to keep seeing me, and I took care of their grandkids or whatever. That's great. Long story short, they were getting opioids, And I had concerns, but it was actually appropriate for the disease and some of the comorbidities. They couldn't take all opioid alternatives and whatnot. But finally, I was like, you know what? This is kind of bullshit. I don't know that this isn't all adding up, right? You coming down here, and it was during COVID. Oh, I can't come. I'm so terrified. All these problems. I don't want to come to the office. Don't want to come to the office. Long story short, part of the so you have to have somebody sign, and when you work for like a hospital-based system, they have to sign a opioid or controlled substance agreement. Fine. You have to do a random urine drug screen in order to like hold them accountable.
Mm-hmm.
Fine. This person's urine drug screen was negative for all the opioids that were being prescribed.
So
I'm like, this doesn't make... Actually, what happened first, back up. The DEA shows up in the lobby one day, and one of the secretaries comes back and says, hey, so-and-so is here to talk to you. They said they don't mind waiting. I'm like, oh, this is probably legitimate, right? Mm-hmm. So they say, hey, I just want to let you know so-and-so, we have a high reason of suspicion to believe so-and-so is selling their scripts in such and such a place. I'm like, oh, this is interesting. So then I have the person come in, I get the urine drug screen is negative. I'm done. Like, I'm not sending these.
Mm-hmm.
The administration, well, we reviewed your notes. This is not my collaborative physician, not the chief medical officer. This is the administration, people who don't have any medical degree. Some of them don't have any college education, which I have no issue with people without college education, be administrator and being, they have more years experience than I do. Mm-hmm. But I've taken classes in, prescription writing, legalities, pharmaceuticals, right? So I said, I got to discharge so-and-so. Oh, well, we did a thorough chart audit and you didn't have a good face-to-face conversation. I'm like, wake up. There's an opioid epidemic or endemic in this country right now, So I know that when I hit that send button on those oxycodone scripts, they're not going to Paul. Mm-mm. So you're going to tell me I can't discharge Paul? Well, you could, you don't have to write those scripts, but, no, you can't discharge them because then we're liable for abandonment. I'm like, this is bullshit. Long story short, I said, I'm not doing this anymore to the woman. Fast forward 2 months later, I get a sexual harassment complaint.
Oh, God.
The woman said that at her last office visit, I offered her to dinner and she said no. And because she said no, that's why I was discharging her and terminating her opioid prescriptions.
Oh, God. It's like, who needs
and that was, for me, that wasn't all I needed, but that was kind of like the push over the cliff. I was like, you know what? I can't do this anymore because there's, nobody's looking out for me, right? And here I am. I can't do the right thing. The right thing is to not keep refilling these meds.
Mm-hmm. Mm-hmm. Yeah, gee. And it's like, you want your providers to be clear-headed and to be able to help you as much as possible. And it's like...
And you can't really act on what's right, what you've been trained. You just got to act on, the protocols. And
mm-hmm.
To me, I'm like, number one, yes, I had this person sign a, controlled substance agreement. Number two, it's common sense. Like you have a DEA, Drug Enforcement Agency, in your lobby saying, I have concerns about where these scripts are going, and we have reason to believe. And I have somebody who, can't afford much, has to take subsidized transportation to my office. There's every reason to believe they're selling those scripts. Clearly, mm-hmm. like, why else would they come 40 miles, right?
Yeah. Jeez, dude. How much?
And then, that's a whole separate, 3-hour conversation is...
With what?
Subsidized healthcare, right? Or federally funded healthcare. And that goes to Obamacare and the Affordable Care Act. I think it's, I'm all about access to healthcare, but I really feel like since Obamacare, I mean, it widened the range of people that could be covered, mm-hmm. right? So more people are eligible for Medicaid and subsidized healthcare, which is great. But what I feel like that did is really kind of choke the middle class.
Explain.
Because, I speak from experience, middle class now has these healthcare premiums that, working class families can't afford. Mm-hmm. People who are in the lower tier get qualified for the subsidized health plans, which is great for them. But again, I have seen now what's happening is, again, working class people, you got these high deductibles. How can a family, working class family, let's say a blue collar or, a teacher and mm-hmm. a cop.
Yep.
you're paying how much a month for daycare? You have 1 or 2 kids in daycare. Now you have, 250 plus coming out of your paycheck for healthcare premium. Then you want to go to the doctor, you got your copay, or you might have a high deductible, right? I mean, it just, the cost just isn't there.
The supplement industry is like the Wild West. The lack of regulations mean the supplements you purchase may not even contain the ingredients listed on the label, which is why I get my daily vitamins and supplements from Thorne. Thorne vitamins and supplements are made without compromise. Quality ingredients ensure your body optimally absorbs and digests your daily supplements, while in-house and third-party testing ensure you're getting exactly what you paid for. Thorne offers a variety of health tests reviewed by board-certified physicians that evaluate your lifestyle, gut health, sleep, stress hormones, and metabolic markers to determine which vitamins and supplements may be most effective in helping you feel and perform better throughout the day. For college and professional athletes, Thorne has NSF-certified supplements that make sure you won't get positive on a drug test. Whether you're an athlete, professional, parent, grandparent, or weekend warrior, Thorne's selection of high-quality supplements can help improve your quality of life. Switch to Thorne's high-quality and extensively tested supplements today at thorne.com/u/CDSF. That's thorne.com/u/CDSF. This episode of Off Exit 10 is brought to you by Bombas. Bombas makes my favorite pair of socks, hands down, alongside the most comfortable and durable underwear, t-shirts, and other everyday clothing staples. Their wide variety of sock lengths, colors, and patterns have you covered, whether you're working out, going out, or lounging at home. I love their merino wool blend athletic ankle sock for long days of coaching at CDSF and getting in workouts myself. And if I'm at home doing work around the house, you better believe I'm wearing my Bombas Sunday slippers with their comfy memory foam midsole. And when you buy from Bombas, you're also buying for those in need. For every item you purchase, Bombas donates 1 item to people in overnight shelters, transitional living facilities, rehab centers, Title I schools, and medical service professionals. Take my word, if you want to upgrade your sock game to one that's more comfortable, durable, fashionable, and charitable, head over to the Bombas link in this episode's description to browse their full collection of everyday wear, and don't forget to use code CDSF20 for 20% off your first order. Yeah, but it's like, what's the fix? It's like, this is different than like a universal health care, like a Canada situation,
which I'm not against,
Right.
I took some notes on that last night as I was thinking about it. I mean, I have mixed feelings, right? Pros and cons. The pros is everybody gets care.
Right.
Is it a right? No. One thing, personally, one of the reasons I'm about it, long term, it's going to be cheaper, right? When I was in school 20 years ago, it cost about $1 million a year to keep somebody with dialysis alive.
Right.
Keep somebody on dialysis alive for a year, right? Now, if you took that person when they were 20, got them good access to health care, primary care, endocrine care, maybe they were type 1 diabetic who didn't have access to insulin.
Right, you're paying less than that person over time.
Right, you're basically keeping them healthy. They're costing less every year. They're not as sick. Number one, they're not as miserable. Number two, they're functional. They can go to work. They could have their own health insurance. But if they didn't have it at a younger age because they couldn't afford it,
right,
they're screwed. Or, you look at colorectal cancer screening, right? Somebody goes for colonoscopy. They have a precancerous polyp. Boom, it's removed. Great. Come back in 3 years. Somebody doesn't go for that, that colon cancer screening. They wind up with stage 3, stage 4 disease.
And that's the first time they're getting seen.
It's metastatic. Now you're talking, instead of a colonoscopy screening, you're talking about, surgery, chemo, radiation.
Right.
They're out of work. They're no longer able, to provide for the family.
So those are big pluses for like a universal care. What are downsides that you would see from you being in the business?
Well, number one, can we
afford?
How do we produce that much health care
Right.
for the people who need it?
Right.
I also don't think it's fair for people who work and pay into a system to get same care for people that haven't
Right.
paid in, right? So
Right.
I'm not politically savvy.
Mm-hmm.
I would think some type of like tiered system would be the way to do it.
We talked about a couple of podcasts ago where a lot of health concepts get politicized, right? Like with RFK in there now, people hate him, people love him. But these concepts get politicized, whether you're in this camp or in that camp. And I'm like, can we just remove ourselves and look at things objectively from a healthcare, from a keeping people healthy, from a scientific standpoint? It's hard to avoid
I feel
that.
like before COVID, that was a non-issue, right?
That's
and
a
then
good point.
COVID just ripped the healthcare apart.
You felt that, or the effects after?
Oh, I mean, every day, people and we had the election in the middle of it. People came in, Biden this, Trump this. I'm like, how's your cough? Well, Donald Trump. I'm like, hold on a second. I don't think he got you sick.
We saw that in here. You're right. You're like, can we just goblet squat right now?
Can we just do a step up? Just push the sled. Just push the sled. You know what? Go to the bike. Actually, you're in timeout.
I mean, I'm trying to think of like direct examples over the years, but never before COVID did I have patients actively like engaging in political conversations, and it just number one, it doesn't belong in the office, right?
Yeah, 100%. Political conversation in general, or political conversation connected to health and healthcare?
I think both. I think it was just like an accelerant, right?
Yeah.
It was like gasoline on a fire.
Mm-hmm. Yeah. Do you feel like people, and this is where you doing what you do, I think plays well post-COVID, because people really want somebody that they trust. I feel like you saw, especially during COVID, this amplification of a distrust of media and a distrust of, I guess, maybe the medicine via big pharma and pharmaceuticals.
Yeah, I mean, again, I feel like people, first off, everybody wants somebody to blame, right?
Yeah,
like,
of course.
No, they made me get that. They made me get that vaccine. Well, the vaccine came out in, what was it, December 21?
Yeah, around the, yeah.
I think it was accessible either December 20. Let me actually, where was it?
Yeah, around that time.
Yeah, so December 20 is when the vaccine got the emergency use authorization, and it started becoming available in January 21. March through June, you saw that, hospitalization and deaths just. So people who are going to say the vaccine didn't work, people who want to stand on their head and say the vaccine didn't work, it's like, I have a hard time believing it. I can't sign off on that. Now, if you want to tell me that, people should have been mandated to get 5-6 vaccines.
Different conversation.
Right, but I think it's, stop the bleed, right? It was kind of like, we need a solution. We don't have 18 months, 2 years, because, I mean, thousands of people were dying, tens of thousands of people were dying every day.
Mm-hmm. But then a lot of people will talk about adverse reactions to it. Like, how much of that did you see, if any?
There was some. There's a lot of still casual relationships where there's not much that's been absolutely proven, right? Like with the pericarditis. Well, yeah, the vaccine, some people, the vaccine had developed pericarditis afterwards, and it's associated with the vaccine. You know what else causes pericarditis? Viruses, and they're a lot more lethal.
Right.
Mm-hmm. And there probably would have been a lot more of them. So again, you got put things in perspective.
Yeah. Yeah, that's a good point.
Like, how many of those people that died during COVID had pericarditis during that time?
Or had comorbidities.
Or like some sort of like
I mean, and
heart
there are,
issue.
like look at the, it's a similar casual relationship with the HPV vaccine with, stimulated autoimmune conditions because of the way the vaccine works. People are still, getting the HPV vaccine. I mean, I got my kid, all three, I think at least two of them, if not three, have all gotten it. I'm not afraid, ashamed to say that. It might stimulate an autoimmune condition. If they already have it's not going to give them an autoimmune condition. It might stimulate it, but guess what? They're also less likely to die from, different cancers.
Right. Yeah. What are most common cancers that you see now?
Thank goodness, honestly, I don't see a ton.
Yeah.
Lung is colon. Your big ones are like, your lung and colon and your leukemias and lymphomas.
Yeah, and those. Yeah, it's like as a primary, what's the kind of main role you see yourself as? This person who's facilitating care to different places?
So that's a big part of the direct primary care model is, it's about access and it's also about advocacy.
That's a great point.
I had somebody recently who, a guy has bladder cancer. I've known him, I think, probably over a decade or thereabout.
Do you feel like you're able to advocate better now in the model you're in than prior, or the same?
I think, I don't want to say that I'm like a rebel or cavalier, but I've kind of always done what I think was right, regardless. Like I have a guy, he's in his 90s. He has bladder cancer, just went back to the urology group he had gone to the last time he had it. And, he went a few weeks ago. He has hearing problems, right? So it's complicated. basically I get a note back saying, oh yeah, we're going to go to the OR, take this thing out. I'm like, whoa, time out. And he also has a spot on his lung that might be metastatic from the bladder that I had actually called the urologist's office and said, hey, just, so-and-so's coming in. They have a spot on their lung. It might be related to the bladder. Guy's 94 years old, doesn't want anything too aggressive. And I get this office note back. Mr. So-and-so is in. We're going to go to the OR. So I called his daughter because, again, he has trouble hearing. And him, his daughter, and his son came in, and we all sat down and, chatted for, 25, 30 minutes. I was like, you sure you want to go through all this? The guy's like, oh, absolutely not.
Yeah.
All you had to do is ask.
Right.
Do you want to do this?
But I think having an advocate and having a relationship with somebody who can be your advocate is so important. I spoke about it with the girls a couple podcasts ago. But yeah, my wife and I both kind of work in the health field, so we have a general understanding of how the healthcare system works and of the body. But if we didn't and just kind of blindly listen to people and weren't able to kind of make our own decisions,
Well, and there's so much on the internet, right? I mean, you could find, if you want to find that, caffeine is healthy for you, if you want to find vaping to be healthy for you, just
you can.
Google, can vaping be healthy for me, right?
Yeah.
I'm sure something positive will pop up. More, maybe less vaping, but you could, customize your search to get the results you want.
Mm-hmm. Yeah, that's a good point. Yeah, how much is just education on what you do, too? That's so important.
A lot, a real lot. So, and I tell people all the time, do not go to the internet. Just give me a buzz, shoot me a message. I'll give you a call.
Well, I feel like going to the internet a lot of times then creates anxieties.
Great point.
Because you're going to create immense anxiety.
Because you're like, oh, it could be this, it could be that, but it could be this, which could be anywhere from nothing to death. And you're like, where am I on the spectrum right now? And that's where don't try to be your own doctor. Contact your doctor. Go. See
Google
somebody.
Chest pain, right? What I'm having chest pain. What could chest pain be? Chest pain could be you're having an MI. If you're 30 years old, way less likely. Not impossible, way less likely. You could have pulled a muscle working out. You could have acid reflux. It's a zillion things. You could have anxiety, but if you go to the internet, you'll probably wind up in the ER. All hooked up. It could be a blood clot.
Or you'll end up in the corner of your house in a fetal position. One of the two.
Or you could blow it all off and you could wind up dead. So, there's lots of possibilities.
Dude, we brought our kid to the ER the other weekend because she had croup.
Yep.
Just the sound.
That's probably, a more
terrified.
reasonable.
The sound terrified me, dude. Oh, my gosh. Scary. She's all good. We got her there once her oxygen was good. I was like, she's good.
So did you call the pediatrician before you went?
No, it was at 1 a.m.
Yeah, so why wouldn't you call a pediatrician?
Yeah, I don't know.
Because honestly, I've told you in the past, you're welcome to just shoot me a text. I would have said, hey, bring her outside, because that's the treatment for croup is the best treatment.
Yeah, that's a great point. I'm sorry, Ryan. Yeah, I should have just called you.
Excuse me,
but
sir.
No, I had somebody again, recently who went to the ER. Her blood pressure was high. Because, everybody says, oh, you should check your blood pressure at home. Well, and, these old people sit around with nothing else to do. My parents, a few months ago, I went to just my parents. Oh, Dad's blood pressure's high. I'm like, okay, how does he feel? He feels fine. I'm like, okay, then put the blood pressure cuff away. Go to his doctor and let them deal with it. So I told one of the patients, I said, you have my cell phone number. That's another thing with the direct primary care model. And my attorneys kind of don't like it because it's not HIPAA encrypted. Now there are, third-party sites a third-party resource I could use to make sure the texts are HIPAA encrypted. Right. But basically when you join my practice, you sign a consent saying, hey, I want to be able to text Ryan or, his coverage. I know it's not HIPAA encrypted, but it's a hell of a lot more convenient than going to urgent care or the ER. So I told one of the patients, I said, why didn't you call me? She said, it was 11 o'clock at night. I said, do you realize that if you would have called me, I would have told you to go back to bed and we could have addressed it at 9 a.m. Instead, you spent 8 hours in the ER and probably a $6,000 or $7,000 ER bill for what would have been resolved with, or I may have said she had blood pressure meds at home. I may have said, take an extra one of this and, we'll catch up in the morning.
Yeah, it's a good point. Yeah, we brought Sia there. She was fine by the time we got there. We sit down in the room. Nurse comes in, and she just points to the television in the room and goes, that's a small TV. I go, fucking spoiled this kid already.
Yep. Yeah. The other thing, going back to, we talk about advocacy, but also just utilizing and as you were alluding to, navigating the healthcare system. Orthopedics, all the time I talk about orthopedics. Your daughter falls on trampoline, the trampoline, or twists her ankle or something, right? Or like, oh, I gotta rush to urgent care. Gotta go to the ER. Well, go to an urgent care. About 30% of them don't have an X-ray tech now. Again, pre-COVID, that was never an issue. Through COVID, whatever happened with the healthcare system, people left because of vaccine mandates. People said, this sucks. I don't want to do this anymore. It's really hard to staff X-ray techs now. So you'll go to urgent care and there's no X-ray tech. So it's like, yeah, you hurt your ankle. Let me get you an ACE bandage and give you a number for an orthopedist.
Right where you would have ended up before.
So what I tell people is, give me a buzz, because like in our area, there are 2 orthopedic groups that have walk-in urgent care clinics. You call me on a Saturday night, hey, I twist my, all right, no problem. So-and-so has, opens at 9 a.m. tomorrow. Just take some ibuprofen, ice it. Now, if you're like, hey, I fell down 3 steps and my leg is dangling, that's a different story. But we could get you in with the appropriate orthopedic group. So when you leave there, you've had the X-ray, it's been read by orthopedic professionals, you're splinted appropriately, and you're on your way. Any urgent care you go to or ER, read the bottom line. It always says follow up with PCP or follow up with ortho, right?
Always.
So you're going to go to an urgent care for an orthopedic injury, which is okay, but inevitably you're being referred to orthopedic. So why don't you just go to the first place, the right place the first time, because they had this now. Same with ENT. There's a walk-in ENT group in Albany now. Yeah, but again, if you don't know what groups and what the hours are and who works there.
And this is where you doing your practice now, you can just, the ease to be able to communicate with you can bypass some of these steps.
Yeah. In November of this year, you guys, I keep checking my phone. So the office phone rings, my cell phone rings.
You haven't paired up.
So November of this year, I was driving my stepson down to North Carolina. My wife and I were moving his stuff down. I'm sitting in the hotel in Virginia eating breakfast, and I see somebody. I'm like, hey, what's up? And my nurse was maybe she wasn't even in the office yet. It was like 8:15. She's like, oh my God, I fell. She hurt her ankle, knee, and I think her shoulder or hip or something. She's like, should I go to the ER? What should I do? And it was like literally 8:20, 30 more. I said, give me a couple of minutes. I said, give me like half hour, Dara, or I will call you back. I called Dara. She called the orthopedic group down the road from us and down the road from where this woman lives. She had an appointment at 11 a.m., went in, saw the orthopedist. I think she broke her ankle, was splinted, out the door, no urgent care, no ER, no bullshit, no in between. Like, get it done and get back to life.
Mm-hmm. Yeah, that's incredible. It's like if anybody has hang up for like cost or why I'm going to do this, it's like just think about, I guess maybe harder to say if you're just like a healthy person, but like you can't anticipate what's going to happen.
And that's what I say to people, like your guys' ages in your 20s and 30s, right? I mean, the likelihood is, you're probably not going to need it, but what's it worth to you? Do you mind sitting in an urgent care for 3 hours?
Right. And it's like, I know my anxiety, and it's like, yeah, you know it too, Paul?
Yeah.
You know it too, Ryan? But it's like, I don't want to deal with these things, and a prolonged urgent care sit or delaying me getting an answer. Yeah, but send me
down a dark path.
Yeah,
especially if you're there for yourself too.
Yeah.
Yeah.
So yeah, the direct payment, again, it's an out-of-pocket expense. A lot of people, when I left my last practice, I already pay enough for health insurance. 100%, we all pay way too much,
dude. And they increase. I mean, I covered guys' health insurance and here for work. I think they gave us an 11% increase last year. This year, at least. And it's like, Jesus, man.
There was a company I was talking to in Columbia County. They were looking at a 42% increase for they have like 180 employees.
That is wild.
But again, I pay so much for health insurance. Number one, you do is another $1,200 to $1,500 a year going to break the bank.
Right.
Going to tip you over the edge? Probably not. You might wind up saving money at the end of the year because you're probably going to utilize less health care.
Mm-hmm.
The other thing is, yes, you pay that, but are you satisfied with what it gets you? Because what it's going to get you is a physical and go to urgent care. That's another thing with all these big groups, man. They all have their own urgent cares. They want their schedules filled before they open up. This is another argument I used to have was, I felt like we had 4 providers in the office. I felt like each of us should take an afternoon and just do sick visits, right? So anybody could get in. Oh, well, what if we don't have enough people come in that day? I'm like, okay, so for a little light one day, which when you have 4, 5, 6,000 people is probably not going to happen.
Right.
Mm-hmm. If you're a little light one day, you're going to be heavy the next day. You'll make the money back. But my colleagues didn't want to do, I don't want to see your patients. I only want to see my patients. It's like, what are we doing? Like we can't function where we open the door, our schedules are stock full. So if somebody has an acute issue, well, and it doesn't always have to be physical, right? What if emotionally, like, you get somebody who just is having a rough time in life and needs to come in and talk to you for 40 minutes, right? Or if you get somebody who's suicidal, oh, go to urgent care, go see some PA who graduated from, college 6 months ago.
Who doesn't know you?
Who, by the way, doesn't know you. Yeah.
Doesn't know anything about you.
But that's also from an economical standpoint, that's a money grab, right? Because insurance reimburses more from urgent care. So if, let's just say, Capital District Sports and Fitness owns their own primary care office, but they also own an urgent care, they're going to make more money by having that, that primary care office stock full and then trickle people to urgent care because the insurance company is going to pay you more to be seen at urgent care.
Yeah, dude.
Years ago, when we were a private group, we had an urgent care, we had our own lab, we had our own imaging facility, and we got bought out or merged, however you want to look at it, with a hospital-based system. And one of the first things they did was took our labs out. We're like, why are we doing this? Like, we are a machine here, right? Somebody comes in for, fever, electrolyte, lightheadedness, dehydration, abdominal pain. We did labs, we did imaging, we had a diagnosis, great. Well, if they need all that, they can go to the ER. We get reimbursed more. Like, not a little bit more, like a lot more. And then the imaging left. And all of a sudden it was like, what can we do to keep people out of the ER? Well, you just said you're going to make more money if you send people to the ER.
So they're incentivized to send people to the ER.
Yeah. So it's like, what the fuck do you want? Do you want people to minimize, expenses and stay out of the ER, or do we want to send people to the hospital because that's where you get the most money?
Yeah, it's a prime example of just corporations and insurance kind of running our health.
Yeah. No, it's I mean, everybody says the health system's broken. I don't know what the answer is. Quite honestly, I think you need more people who are willing to kind of stick their neck out and say, hey, this is fucked up.
Yeah.
I'm getting out.
Like, do you foresee more people doing what you do in the future? I mean, you have to be entrepreneurial. You have to be motivated. You have to see the flaws in the system. You have to. There's so many factors that make somebody step out.
You have to have a support system, right? I mean, my family, my wife. I definitely needed some people, and I kind of engaged a third-party business. I've been down this road. This is trip 4, right? So I had business plans going back to like 2013 or 14, and I pulled out when I met with the business consultant last year. I pulled them out. I was like, well, here's where we are, and he says, you get to the same point every time you do this. He's
like, you've tried to do this in the past?
Yeah. And he says, you get to the same point every time. Why do you stop? I said, because the economics aren't there. So we talked about like concierge medicine, which basically what I do is concierge medicine. I don't really like that name.
That's what they called it in Boston when I was there. They all
I mean,
it
there are subtle differences. So concierge can pay like an annual fee. So and usually it's a lot more. So like my price points are, and it depends if you're a single individual, a single couple, pre-existing patient, but it's its average is about $1,300 a year to give you like a benchmark. Concierge practices will charge typically more. Boston, it's like an average like $4,000 to $5,000 a year, and then they charge your insurance on top of that every time you come in.
Why are they?
So it's basically like you're paying to be a member there, and then they're gonna milk the insurance. So that's the difference between concierge and direct primary care.
Wait, they're billing. Why are they billing the insurance?
For money.
Just to get more money.
So no, but I was saying, so the business consultant I work with, who's never done anything in the medical field, last year we met, and he says, listen, I want you to do an exercise. He says, go through your last 12 months of data, figure out what you would have got reimbursed for each visit, and see what you would have made at the end of the year. He says, then see how many people you would have to have in your panel, and how much you would have to charge to basically get enough money to survive and sustain. And I did it, and it was like the reimbursement, because then if you're going to take insurance, you got to have a coder and biller.
So you're paying somebody for that,
right? You got to have more. You got to have more office staff because you have to have somebody rooming who's going to check all the boxes and do all the bullshit. So you got to have at least 1.5 more FTE. So it's like the cost just keeps going up, and the reimbursement was less. So it was, to me, I don't want to say it was a no-brainer. It wasn't an easy decision. I really kind of needed the push to do it, but enough people would come in the office and they're like, this sucks, you can't. We worked, again, I don't want to disparage anybody. When you called our office, it rang in a different town.
You know what drives me crazy now is just the amount of automation and like AI and computer stuff you're getting through before you get to a human.
Yeah. Oh, yeah. I mean, we would have people. I've been calling. I called for 2 days. I couldn't get in. Yeah, I'm not. I hate this. I'm not surprised. Now it's like, hey, I don't feel good. All right, what time you want to come in?
Right.
I feel like you gotta hit 0 till you get to a person. Like,
Even
I don't
then-
want to talk to a bot. Just keep.
Even then, it might just be you might just be doing leaving a message.
Yeah, I might just be leaving a bunch of dial tones because I'm hitting the 0 button too many times.
Yeah, and there's a big difference between, I've been having some shortness of breath for the past few days versus like, oh man, I really can't breathe, or hey, I've been having trouble breathing. Okay, well, I know you have iron deficiency anemia, and I know you need to get in and get your labs drawn, and you might need a unit of blood, or you have COPD versus somebody else who has oh, I just got back from a cruise. Well, again, maybe you have that PE.
Yeah. But that's big too. Somebody just knowing your whole health history, because then the decision making is going to be much quicker and probably more accurate.
And it's expeditious, right? Again, going back to like the anemia thing. If I have somebody who I know has a history of iron deficiency anemia and is like, hey, I've been having trouble breathing lately, it's like, all right, why don't you go get your labs drawn and I'll catch up with you tomorrow? Versus like, hey, it's Monday, come in for an office visit on Wednesday. We'll get your labs drawn maybe Wednesday afternoon, and maybe by Thursday we have an answer.
Right. This episode of Off Exit 10 is brought to you by Anchor and the all-new Anchor Pro, crafted to endure the most high-performance workouts without the high cost and space requirements of a standard cable machine. Named the best portable cable machine by Men's Health Home Gym Awards, Anchor provides the full functionality of a cable machine in one small space-saving unit. Designed with user-friendliness in mind, Anchor can simply be attached to any squat rack or placed on any wall in your home gym using its intuitive sliding track mount. With up to 65 pounds of resistance, Anchor is built for high speed and controlled exercises alike, from cable presses and rows to chops and lifts. The Anchor has been a game changer for us here at CDSF, and now you can enjoy the same professional quality cable machine in your own home gym by heading over to anchortraining.com and using code CDSF10 for 10% off your order today. Get all the benefits of a cable machine without the high cost and installation fees. Enjoy the portable luxury and space-saving performance of Anchor today by going to anchortraining.com and using code CDSF10 at checkout. That's anchortraining.com, promo code CDSF10 for 10% off your order today. This episode of Off Exit 10 is brought to you by Drink Alchemy. Fatigue and brain fog affect us all, destroying everything we pursue. Whether as an athlete, artist, creator, or entrepreneur, our mind holds the key to performing optimally. By combining the most potent organic nootropics found in nature, Drink Alchemy delivers sustainable boost to creativity, memory, energy, and focus in one epic beverage. Stop pumping your body full of excessive amounts of caffeine and unknown proprietary blends from other energy drinks, and get clean energy from Drink Alchemy's natural nootropics like lion's mane, L-theanine, and caffeine from green tea. Used by Olympians, D1 athletes, MMA fighters, and entrepreneurs, Drink Alchemy has become a huge part of my daily routine, making sure I'm functioning optimally during long days of coaching athletes, running CDSF, and getting in quality workouts myself. So do yourself a favor and ditch the energy drinks loaded with caffeine, other stimulants, and who knows what else, and head over to drinkalchemy.com today. Live with your mind unbound and save 10% off your order by using code CDSF at checkout. That's drinkalchemy.com, promo code CDSF for 10% off your order today. How much, speaking about like bots and computers, how you use like ChatGPT or any of that ever?
I don't know what that is.
None of that. It's like the AI. Explain it, Jay. It's
We're like old school. I mean, the only kind of progressive stuff we have is that when you call the office, my phone also rings. I mean, I don't even know how to transfer a call from one line to the other. So
You just said hit the forward button and we're good. We're good. I just need to forward to my phone. So
It's like the AI, like I don't know, like instead of Google searching, you just put it into that and it just draws upon the whole internet. We'll use it to like speed up some stuff in here. But your social media copy, we'll use it for that. Mm-hmm. Yeah, how much? Because now you have to market for yourself, right? That's a whole nother beast that people probably don't think about.
Yeah, I mean, I've been lucky, so I don't think we've done any marketing.
Yeah, that's good.
The only marketing we made some fly, like handouts on what we do and kind of cards. I'm trying to think of our marketing expense. We haven't. We have Facebook, but I mean, we're not getting. We have a website. We're not getting patients. It's all been word of mouth. I'm starting to look now at kind of what we're going to do as far as marketing.
Yeah, the word of mouth is big. I mean, that's what we've been here for so many years, word of mouth. And I mean, we're heavy on social media, but we've paid nothing for advertising other than like if a kid asks us to like donate to his team and the family's been good to us, we'll do that. But that is about the only paid marketing, Paul, I think that we've done.
Yeah, pretty much.
The other part I'm looking at, and I've talked to a couple of local businesses, and I've got a couple of conversations going, is I kind of want to, get an account with a local business. Like, hey, you have insurance, but your employees can't use it because the office is always full, or there's no access. How much, and extend it to the families, right? So your daughter wakes up, her ear hurts. Do you want to deal with calling the pediatrician and what time can I get an appointment? We're just going to urgent care. Or would it be nice to know, like, oh, hey, I could just go down to Ryan's office, he'll peek in her ear, and you're back to work by 10 a.m. She's in school. Everything's done. Oh, and there wasn't any copay or any extra expenses.
Yeah, that's huge.
Yeah.
Are there scenarios within your practice where you will then use insurance for things, whether that's referring somebody out to imaging, they're going to use their insurance, going to do
Yeah, and that's where I think kind of the future of primary care is going to go. Is so I still use patients still have insurance, right?
I think people think that, well, like what you said earlier, well, I'm already paying this much for insurance, so why am I going to pay you additionally? Like, I'm going to pay you for my peace of mind, for the ease of access. Efficiency.
Getting to the problem and getting the solution as soon as possible.
But
and dealing with the same person, right? So insurance is I'm not going to, I don't want to say like insurance is a waste of money. No, you need insurance,
well, because
right?
we wouldn't have, I know I sit here and shout insurance on multiple podcasts, but like we've done, I don't know how many rounds of IVF, and dude, there's no way we'd have a kid or been able to do this without insurance, man. No way.
Correct. So insurance is good for labs, imaging, specialty, services, hospitalization. I just don't think, I think this system is so overloaded that I think if you want, good primary care, and quite honestly, it minimizes and prevents unnecessary urgent care and ER visits. That's what I do.
Right.
Yeah.
Right. So you think the future is
like a blend of like.
I think if you want good primary care, you're going to have to pay for it,
right,
because I think enough people are already doing it, and practitioners who've been in the game long, there's like this window of people who have been in primary care. I'm 43. There's not many primary care providers my age. Nobody wants to do it, right? Because it was disparaged for so long. Because quite honestly, it's like the grunt work. You do all the work. You have the lowest reimbursement. And you have to take care of people's blood pressures, people's thyroids, people's diabetes, depression, rashes, after hours, URIs. You go to a cardiologist's office and you work there. It's like your blood pressure's good. Go home.
You're saying a lot of them are older. It's not a
so the folks that are older than me, like in their 60s and 70s, basically, COVID kind of pushed them out the door,
right?
And nobody wants to get into it now.
Right.
So there's a lack of primary care.
There's a huge lack
because of
the
model, the system not wanting to deal with that and work in that.
Yeah, because we used to, people, again, who are older than me, worked in the model where it was privately owned,
right,
and it worked. And unfortunately, the lack of reimbursement pushed them into the hospital-based system, which most of them don't want to be a part of anymore.
Mm-hmm.
And then the younger generation, nobody wants to do it.
But do you think now, having this be an avenue, hopefully we'll see some younger people
I think
who
people
care.
are starting to get into it, right? But I'm just, small fish in the ocean. I mean, there's a couple of thousand direct primary care practices across the country, and there are, there's more concierge practices popping up.
Mm-hmm.
So, I think it's going to continue to grow. Do I think I'm going to be, the person who makes it all happen? No, I'm not that excited. I'm not that motivated. I'm not involved with politics. I'm not involved with social media. I kind of like to do my thing and, go hunting and fishing.
Yeah, I think that's a peaceful life. It's it's an interesting part about in here. It's like, I said it last time, but I am so introverted in here. It's like I'm so on and doing my thing. But I would just like to be at home and be peaceful and be with my kid.
Just like to relax when I get home and like not have to stress too much.
But that's also what this has done for me is, I met with a nurse practitioner a few months ago. She's been out of school 2 years. I've been out of school pushing 20. She's seeing over 20 people a day. How do you start at 8 a.m., go to 6 p.m., remember everything you talked about, talk about all your seatbelt use and all the bullshit.
And safe sex.
And safe sex. And, like don't smoke, skin checks, right? Like I'm like, when you come into my office, people are like, what do you I'm like, how long has that mole been on your cheek for, right? And they weren't there for a mole, but I'm in tune to that shit. But when you have to see 20-something people a day, you don't give a fuck about the skin. The skin, it's like, your ear hurts, here's some antibiotics. Go. Because there's 3 people in the waiting room, who have other problems.
And two of them showed up 10 minutes late.
Yeah.
Probably. Yeah. Yeah.
Yeah, that's a good point. Yeah, I don't know. I don't think,
Another thing I want to go back to, and,
What?
I know I've kind of
You bounce around.
occupied a lot of lists, but you gave me this energy drink, and I'm like, I'm ready to go. But
yeah, let's go.
no, the labs you talked again talking about insurance. So I have 2 lab companies that I draw labs right in my office. So again, if you come in for something, it's not like, okay, go to your local lab. It's like, done, go home. I'll call you tomorrow, and it's it shows up in my phone. A lot of times I check labs before I get out of bed in the morning, partially just because I have too much energy, and I'm passionate, right? So I like to see what I'm doing, what's the day going to bring. But so I check the inbox and I'll see the labs from the day before. But what I was getting at is there's uninsured patient pricing. So if I see somebody who doesn't have insurance, I could draw your labs and I have to put a stamp on the lab slip that says uninsured patient pricing. It's like 30% cheaper right there. Boom.
Cheaper.
Wait.
It's discounted.
Because you don't have insurance.
Because you don't have insurance. So now you're paying anywhere from, let's say, a best family plan. You're not getting a family plan under like $200, $250 a paycheck, right? Mm-hmm. I have people who are self-employed who are paying $800 a paycheck, plus they have an $8,000 deductible. How much? My wife, our insurance, we gave it up a few weeks ago. We were $14,000 out of pocket a year before our insurance kicked in. That's because it was like $270 a paycheck, $8,000 deductible, and then it went to co-insurance. I don't even know what that does. I'm like, you know what? Let's just pay for it and move on with our life. God forbid something bad happens, we'll cross that bridge. Statistically, that's not going to be the case, but it's to some extent it's a measurement of risk, right? How much risk are you willing to take? Do you want to lay the money up out front and may not use it, or do you want to say, hey, if something pops up, we could pay for it?
Right.
Meds. Every pharma company, and everybody hates a pharma company. I've never had a pharmaceutical company really turn a patient away and say, too bad. They have patient assistance programs for people who genuinely can't afford it. They have patient assistance programs. They'll sample. I mean, people want to slam the pharmaceutical company, and I'm not saying I agree with everything or the prices, but I think their executives are way overpaid, no different than the insurance companies. Their sales reps do well.
How much did you deal with sales reps when you were in the hospital system?
I mean, I wouldn't say it's hard to grade like a lot versus a little. I would say we weren't a very rep-friendly office. I was one of the only providers that would actually talk to the reps. And again, like, if you don't talk to somebody, how do you know what's new? Unless you're reading the New England Journal of Medicine every night. But if you're doing that, you're not spending time with your family.
Right.
I mean, the drug reps have a job, but they're also well educated on the disease process and the drugs.
Mm-hmm. You prescribe GLP-1s.
I do, yeah. So actually, you had asked me about that before, and I took some notes on that. So my position on the GLP-1s, I think they have a role. Borderline diabetic, people who are chronically obese. Zepbound just got approval for sleep apnea, right? Like, it's not rocket science. You lose weight. You get somebody who has a BMI of 40, you get their BMI down to 32, they might not have sleep apnea.
Some things are going to get better.
Yeah.
Maybe they don't need gastric bypass surgery.
Right.
I was an early adapter to the GLP-1s, and I agree with them, particularly for diabetes management. Now, they've gone and gotten other indications, like some of them, Ozempic has a cardiovascular risk reduction indication.
We've seen both sides of the coin in here. We've seen people who it's really kind of kickstarted and sparked a lot of change in their life. Like, it helped them lose some weight, and they had confidence to come in here more and work out and make dietary changes and go skiing more and do other activity. And yeah, their sleep's improved, their whole life's improved. Their life is probably going to be longer and better quality now because it sparked these things. But we've also had a couple people who, I don't know exactly the mechanism, maybe you can speak on it, whose gut slowed down so much that they ended up.
So let me just go backwards real quick to the cardiovascular risk reduction. Ozempic, the trizone, right? What is it? Weight loss, glucose management, and cardiovascular risk reduction. Now they just got an indication for CKD, which is chronic kidney disease. But again, you lose weight, your blood pressure goes down, all these things get better.
Right.
Shocker.
The risk, or not the risk, I think it's a patient to treat ratio. So you have to treat almost 600 patients with semaglutide to decrease one cardiovascular event. So now let's talk about the side effects of pancreatitis, the constipation, all the other problems. The one that is legitimate as pancreatitis, man. I mean, that stuff works directly off of your pancreas. That's one of the ways it works. And this is what gets me about these GLP-1s. A lot of these, the boutique pharmacies and the third-party pharmacies.
Is that like the Hims Hers? Is that what that is?
That's some of them, but they're like everywhere now, right? So, and I even had colleagues who I know didn't have this conversation with people. There's a black box warning for the GLP-1s, and it's for personal history of pancreatitis, family history. There's a note about medullary thyroid carcinoma, which the drug was, the drugs have been studied in rodents. Rodents are more predisposed to medullary thyroid carcinoma. People rarely get medullary thyroid. They get papillary thyroid carcinomas, but not medullary thyroids. So it's like a different, that one I worry less about. But I don't think the Hims and the Hers and all these boutique pharmacies and a lot of these providers that work for these huge systems, again, you have 15 minutes. How did you address my blood pressure, my depression? And I left with a script, for semaglutide.
Right.
Those, to me, that's important to have those conversations. Like, yeah, this stuff will help you lose weight, but it's not bulletproof. Anecdotally, we've seen, some increase in gallbladder problems. Again, anecdotally, absolutely GI motility issues. There are issues.
So it's you just making a decision,
a clinical decision, right? And again, what kind of irks me about them is, yeah, absolutely. Somebody who has a BMI of 35 and family history of type 2 diabetes and coronary artery disease, and they're destined for problems. Great candidate. Somebody who has a BMI of 28, who's 40 years old, who wants to get back to their bathing suit body, like. Right. Sorry, bro. That's not where you're at.
Do you have to educate too? Like, if we're losing weight at a more rapid pace and we're not strength training, we're probably losing muscle tissue as well.
Yeah, I mean, I know
it's a lot for you to cover with somebody.
Short answer is yes, but you have to have somebody who's really like invested in the conversation.
Yep.
Invested in that. That's like a whole fitness profile, right? That's not just somebody who wants to lose some weight.
Well, and I think that's like the people that we see a lot of times, like. They've now, they either have already invested at some point into the fitness side of things,
right?
And now they're like, all right, like I know I need to stick with this, and if I can see some change, it allows them to do that, and they're in a health situation where it's also going to help benefit other health factors, I feel like that's where a lot of the clientele that we see that we know of that are on the GLP-1s, they've already gotten to this point where it's like, okay. I've already bought into a lot of the process, but they just haven't been able to, whatever it is, either stick with it or see the results because of other health issues.
Mm-hmm.
So there's a place. I absolutely there's a place for it, right? Particularly in type 2 diabetes treatment, probably in your borderline diabetics, obesity, who are going to be ultimately a type 2 diabetic prevention. But do I think the world needs to be walking around on GLP-1s? Probably not.
Right.
The other thing, as you guys alluded to with the comorbidities too, it's like the hamster wheel, right? So putting on some weight. Why am I putting on weight? My knees hurt, my lower back hurts. I can't exercise as much. Why can't I exercise as much? Because my knees hurt, my lower back hurts. Okay, I don't exercise as much. Sit around. What do you do when you sit around? Hand to mouth disease, right? You just sit around and snack and eat more. Then, your BMI goes from 27 to 29. Now you're putting all that extra pressure on your knees and your back. Now your back hurts more. So you just keep sitting around gaining weight, and your osteoarthritis just gets that much worse, right?
Right.
That's somebody who I might say, hey, you know what? Why don't you think about this? Maybe you don't need to be on it forever. Maybe you do 6 to 10 months. If you lose 30 pounds, and then in the next 18 months you gain 12 of it back, you're still down 18 pounds. Which
but then maybe if they feel better and they're walking more, maybe they don't gain 12 back.
And they may not.
Right.
And it might just be the catalyst, right? Mm-hmm. But over the course of our lives, right, you're better off having those, a couple of years you can get out, move around, do stuff psychologically, you feel better. We talk about, again, objective health measures like glycemic control, blood pressure. What about, depression? It's you feel better, life is better.
Yeah.
Mm-hmm. 100%.
And you can't measure that.
Yeah. What if you have your ideal blood panel for somebody, you have things you want to look at, just generally? What are you looking at?
I don't get too crazy with that because I feel like you could spend zillions of dollars on stuff. And usually if it's not covered by the insurance company, it's
expensive.
Typically, not only is it expensive, but it's also not validated. We have people who want to have these these crazy Lyme type panels and all this kind of, all this other stuff. CBC comp is going to check your electrolytes, kidneys, blood count, liver, size of your blood cell. And it tells you a lot more too, right? Like your LFTs are up. Okay, are you taking too much Tylenol? Maybe you had Lyme. Maybe you have a viral illness, mono. Lots of things can throw different blood counts off, but God forbid, you have like an undiagnosed anemia or just like a macrocytosis or a microcytosis where the blood cell is too big or too small. That could be associated with B12 deficiency, or you could have a normal hemoglobin and hematocrit but have an iron deficiency. So the CBC and a comp every year is great. Vitamin D, I think people go nuts with the vitamin D. We live in the Northeast. Recommendation is 2,000 units of vitamin D every day. We could start, to supplement. We could start checking your vitamin D levels, but then is it like, okay, take this dose, come back in 4 months? No, you really should just take the two, or
Right.
Take a healthy dose once a month. Lipids, absolutely. Again, you could get into your LDL-C and the lipoprotein breakdowns. There's no treatment. Like, the intervention is exercise. Try to eat healthy, try to, be of a healthy BMI. If you have family risk factors, get the appropriate screening. So again, I don't go nuts with blood tests, but CBC, comp, lipids to get you a good baseline.
Dude, the Lyme disease is a big thing around here. It's right. Is it the highest in the country?
Lyme disease is great for business in primary and urgent care in the Northeast.
Well, and ticks can give you a million other diseases as well.
And again, people are obsessed with Lyme disease, anaplasmosis, babesiosis, ehrlichiosis. Those are the ones you get real sick with that. That's where you get your thrombocytopenias, your blood counts drop, you're at risk for bleeding, your liver enzymes go up, you get anemic. So, yeah, I mean, Lyme is huge, and unfortunately, it's not a valid. There's not the Lyme Western blot is a very good test, but it takes 4 to 6 weeks to turn positive. So, if you have somebody who has a known tick bite or lives in a Lyme endemic area, like, in Columbia County, or even up here, Saratoga County, you have enough ticks. If somebody comes in, they're just like, I feel like shit, 14 to 21 days of doxy. Again, if it's somebody who is a one-off, you'll have people who come in, that could be every 3 months. I think I have Lyme. It's like, probably not.
Let's slow down here.
But if you're just like fatigued, achy, I mean, I would tell people, I'm like, I'm not going to wait, for this test to come back positive. It could take 6 weeks. You could have Lyme carditis by then, where it affects your heart. It could get into your spinal canal. It could do some nasty stuff.
Right. Let's just treat it. And what's the downsides?
Well, the downside, I mean, antibiotic use, right?
Yeah,
if you're
right.
somebody who's on antibiotics too much, doxycycline, photosensitivity, you go out in the sun on doxy, you get fried.
Right.
You're watching your kid's game. The next thing you know, you're a lobster.
Yeah. And that can mess up like gut stuff too, right? Like gut
microbiomes. Yeah.
Mm-hmm.
You also don't want kids on doxy unnecessarily because it can mess their dentition up, the enamel. So.
Yep. Yeah. Yeah, man. 1:30, right?
Yeah. Gotta.
Heck yeah, this is perfect.
Perfect.
If you can't tell, I could go for hours. So.
That's what we do. We could keep going for hours.
Dude, this stuff jacked me up. I don't know if you could tell, but like the first
got
20
you
minutes,
going.
you were ready to
Shout
go.
out to Drink Alchemy.
Fuck no.
Shout out to they got 2 more flavors coming, apple and
it's
another
only
one.
75 milligrams of caffeine.
I didn't
The
finish
lion's
it because
mane.
I was like, holy shit.
It's that lion's mane, baby.
Yeah, baby. He's got those
Yeah,
nootropics.
well, that's like now I just supplement for my brain. Like creatine now has good cognitive benefits. Lion's mane. I'll take a fish oil. It's like I just want to stay sharp.
No, this stuff is like, it gets you fired up.
It got you going, man.
Speaking of creatine, my mom's got to drop mine off tomorrow because
You shipped it too?
I shipped it to her house on accident. We share an Amazon account, so
Gotcha.
I forgot to change the shipping address.
There you go.
Dude, this was great.
Yeah, no,
Yeah,
I appreciate
appreciate
it.
Thanks for doing it. We covered a lot, and hopefully just open people's eyes to like this, where medicine probably is going. I mean, we've seen it. My dentist is private pay. PTs we use as private pay. The collaborative women we had on a couple episodes ago. Yeah, just quality people being able to just live a better life for you.
Do what makes sense, right? That's what I tell people. Like I do stuff that makes sense now. I don't just not a square peg in a round hole.
Right.
Yeah. So you want to plug Marshall Health, right? That's what.
Yeah, that'd be great.
So
Yeah, Marshall Health, and I know you say you're not on social media a lot. Do you guys have a social
We
media?
have a Facebook page. Yeah.
Okay.
Cool, and we'll link everything in this description for this episode. So
I mean, is that what you guys were looking for? I know. Like I said, I could just fucking get going.
we are looking for just that, to just open up your brain and go. That's why I do this. It's it's learning. Like
Yeah, I
told you
learned a
before,
lot just sitting here, like a lot. It's probably part of the reason why I wasn't talking as much too, is because I was taking.
Well, I
so
didn't
much
even get into
information.
some of the shitty reimbursement, and we could chat about this, and you could put this in, but you're reimbursed like I say the end of the year, but January 1st they're doing a look back to the previous calendar. This is interesting. So they're doing a look back to the previous calendar year, and they're saying, what were your colon cancer screening rates? What were your mammogram screening rates? What were your annual wellness visit rates for folks with Medicare? eye exams in diabetics, some vaccine, and then you get like your score. And that affects your bonus. But the way the system's set up is you don't have to take like a bonus. You could have it broken out across the year into your paycheck. One year I took on 500 patients. A local physician retired, referred me a ton of patients. I took on 500 patients in the last quarter of the year. The mammograms, colonoscopies, all the stuff wasn't entered appropriately into the electronic medical record, so it wasn't in structured data field. So when the IT people ran their report,
They didn't show.
it didn't show up. I had to write a check back to the organization in February because I didn't meet my quotas.
Even though you technically did, but you did.
It was all in there, and they wouldn't do a manual chart. And quite honestly, I didn't want to fucking deal with them. I was just kind of like, "Fuck you." I brought in 500 new patients. How many in the last quarter? How many office visits? How much did they charge all the insurance companies from and make? And they're gonna bust my balls over for not even the fact that I didn't get the extra money for doing a superior job.
You had to write it back to them.
I had to bend over and give them a check.
Yeah, I mean, to not just be a slave to that is like, yeah, get out of there. I don't like people telling me what to do, so I'd be living, man. So, no, thanks for doing this. This was great. We covered
that
a
was
lot.
awesome.
Yeah, no, definitely. And I'd be happy to come back. I know you said you're done after today,
Well,
right?
We have until the fall.
Until the fall.
People, this is our last one until the fall.
We've had people on twice, so we could do an episode 2. We could do part 2.
Let's
We'll
see how it takes. And where do you guys post it to?
This will go. The full video will be on Spotify and YouTube, and then audio will be on Apple Podcast, iHeart, Pandora. So it's everywhere.
Spotify.
No, definitely Marshall Health. It's 518-732-1800. If we don't answer the phone right away, that just means we're with somebody else. But typically we'll call you back within, usually an hour is like a turnaround time. Definitely not more than 8 business days. So.
Yeah, that's it. We get more lines made in you. Maybe the hour will get down to 20 minutes. So.
You ain't kidding.
All right, Ryan, thank you. This was great, and we'll catch everybody next time. Thank you.